Hello, everybody. Recording live from somewhere. This is Zach Couples with episode number 40 or 40. I never could figure that out of the Movement Debrief. And tonight, folks, I guarantee this one will be in the top 40. We're going to talk about acute pain. What happens if I got a spasm on my neck and I don't know what to do? I'll tell you. We're going to talk about dead hangs from the bar. Should you do it? Should you pack the shoulders? Find out. And then last but not least, we're going to talk about occlusion. That's what's on docket for tonight, ladies and gentlemen. Questions from the people, answered for the people, by this people. Fam recognize fam. But before we dive into tonight's Movement Debrief, a little bit of housekeeping. Did you guys see my blog this last week? So this blog was your good old-fashioned February links and review. There's a lot of good things that I came across the interwebs this past month. There's some good stuff on sleep, good stuff on a lot of different things, and it was probably one of the most impactful lessons I had learned in the past month in regards to how I became a better person. At least I'm trying to be a better person. So please go ahead and check out that. And I didn't hike at all last month. That's crazy. I need to get back on that. So that's also in the docket. Maybe I'll get a new hike of the month this month. We'll see. Actually, I probably won't. Next few weeks are kind of busy. Otherwise, what else is going on in life? Of course, September 15th and 16th, Human Matrix is coming your way to Seattle, Washington. Be ready for it. I just did a bulk of the manual. And yes, if you come to the Human Matrix, you will get a manual, because Big Z ain't cheap. He's going to hook you up with a paper manual. I'm not going to make you PDF it. I'm not going to make you go to Kinko's or wherever you're going to print stuff out and say, oh, here's this. Let me save some money. No, I want you to have the manual there. And it's going to be different than the PowerPoint. It's not just me printing out a bunch of slides and handing it to you. No, it ain't going to be that. It's going to be a good manual. It's going to be one you're going to refer to day in and day out. And we're going to talk about variability. We're going to talk about building power. We're going to talk about building capacity. We're going to talk about building people and learning the code. So go ahead and stay tuned for that. I'm also working on getting some more of those to occur over the rest of the year. Stay tuned on that. Also, I made some good ground this weekend on my case study product, where we go through me treating people and I kind of explain what I do. You get some clinical pearls. You watch how my decision making goes based on testing, and it's a great way to learn. Sometimes the best way is to just virtually throw yourself into a case presentation and learn that way. So definitely check that out. I'll keep you guys posted as I make my way through that. I apologize that it's going as slow as it is, but I'll be working, if you know what I'm sizzling. Otherwise, my weekend was pretty good. I hope you guys had a phenomenal weekend as well. And that's about all I have in terms of housekeeping. Let's debrief, shall we? First question comes from Andrew. Andrew asks, how do you approach someone with an acute hot low back or neck that is in spasm? Every movement hurts them, and even the lightest soft tissue mobilization is aggravating. Let's assume you ruled out all red flags to the best of your ability. So in regards to the red flag thing, when I'm thinking hot low back, we're thinking like a legitimate acute disc. I don't want your namby-pamby. Oh, well, the research shows that 40% of the population who has a disc is asymptomatic. Well, you know what? There's a certain portion of the population that has discs that are symptomatic. They're hot. You get changes in sensation. You get changes in reflexes. You get changes in strength. You want to get them out the door. This door. I don't treat people in here, though. It's my room. But let's say that you've ruled out the big bad stuff, and you got someone who is in acute pain, whether it's lower back, whether it's neck, whether it's anywhere. There's really, sorry, this is kind of sad, but there's really nothing you can do as a clinician that's going to expedite that process. Because the inflammatory process takes time. It takes 3 to 7 days for you to go through that. And so when you sustain any type of tissue injury, whether it's a spasm or whether it's an ankle sprain, whatever, the inflammatory process happens. You get this wonderful mix of neurogenic chemicals and non-neurogenic chemicals, creating this inflammatory soup within the area that's hurt, and that allows you to clean out any bad debris, helps facilitate healing, hashtag love and inflammation, it's not bad, and helps you prepare the area and repair the area so you can get back to being you again. And really the best thing that we can do in this scenario is do things that would help keep that process going in a safe and non-rampant manner. So what kind of things would that be? I still think doing a lot of the variability stuff that I've talked about ad nauseum in previous debriefs, can't talk today, is very much warranted, assuming that it's not painful. Because sometimes you can still reduce some of the acute pain if that person's pain complaint has a variability component to it. And I've seen that a few times. I've seen some people when I was in the league where we had ankle sprains and we did a couple things and I did some manual therapy, and lo and behold, their acute pains went away. And that was even despite some swelling. So you still address variability. I think a lot of local treatments are warranted in this case as well. If you look at, and I'd have to find the link to the study. I don't have it on me right now. And go figure, I'm of course unprepared. I don't have a pen on me as well. But I believe there's a study that showed that manipulation of the ankle in acute scenarios is actually very helpful and can reduce swelling. Who knew? I'll link that in the show notes. But I think manual therapy is very warranted in this case, assuming that it doesn't cause any pain. Now, in your acute pain scenario, Andrew, where you stated that this person can't even tolerate basic soft tissue, then what I would do is make sure you're getting as much motion as you can around surrounding areas. I hate to say it for you tape haters, but maybe you even throw some tape on there, because maybe that light sensory stimulus changes the context enough that it can move a little bit more comfortably. You can also talk to these people about maybe if it's within your scope, and I hate to say it, but taking anti-inflammatories. Because while the inflammatory process is a good thing, it can oftentimes run rampant. And while I'm not the biggest advocate of medications, there's some individuals who aren't taking care of themselves to such a high degree that they have this normal occurring 3 to 7 days inflammatory process, and things continue to run rampant for a multitude of health reasons. Sometimes conventional medicine stuff works, and maybe something like that could be helpful for that person. And educating them on, allowing them to rest for a few days in the affected region. If it's something that they can work through, i.e. train, but not necessarily cause pain, it's a little bit tough when it's axial skeleton. But even doing just any type of gentle exercise, aerobic especially, is incredibly impactful. I remember when I had an acute back spasm, and this was probably a couple of years ago. Believe it or not, I do have pain sometimes. And I couldn't really do much, but I still tried to do as much as I could. So I wasn't training at all. But what I was able to do was some low-level techniques to try to increase mobility. I was able to do the elliptical, and that was actually incredibly impactful. Because I was at least incorporating some short-range rotation. I was getting some benefits of aerobic exercise, which helps increase circulation. You figure that would also probably help improve some of the swelling components, all of these things. All of that's helpful. So I think it behooves you to try to move as much as you can, assuming that you're not impeding that natural inflammatory process. DK Waugh asks in regards to this, any ideas on fluid intake that might help with the injury? I don't have anything off the top of my head, but in terms of nutritional stuff, I would make sure that you are not dehydrated. I don't have anything specific. Typically when you're in a healing process from a caloric standpoint, you should probably not start your fat loss program if you just had an acute injury. You want to make sure you're eating enough calories, and a well-balanced diet, whatever that means for you, is probably idiosyncratic to allow for repair of the tissues. So making sure you're getting your protein, making sure you're getting your carbohydrates, making sure you're getting your fats. All of that's incredibly impactful. I think based on some of the stuff that I've learned from Mike Roussel, which I'll link him in the show notes. And before I forget these, let me just get a pen somewhere. There we go. But when Mike worked with us when I was in Memphis, he's a good guy. You should definitely give him a shot. But we talked about like how can we use nutrition and supplementation to maybe not slow down or speed up the healing process, but how to make sure inflammation does not run rampant. And the two supplements that he recommended were fish oil and Mariva curcumin. And there's some research out there showing Mariva curcumin to be, so Mike Roussel, Hankel, curcumin. There's some research out there showing that actually Mariva curcumin, you can take anywhere from 2 to 8 grams, seems to be helpful for people with osteoarthritis and rheumatoid arthritis. Pretty cool. More so than anti-inflammatories. Double cool, because there's less deleterious effects from you having Mariva curcumin. Does that work in acute scenarios? I don't know. I haven't explored the research enough to say that. Is it going to hurt taking it? If you don't have any contraindications, probably not. It would be something, if I had an acute injury, I would definitely be dosing high on those two things, personally. But I'm not a supplement specialist. I don't play one on the internet. So those would be nutritional things that I would consider. So to summarize, what to do for acute pain. Protect the area. You can still restore variability, but obviously don't do things that are painful because we have to promote a good healing environment. You can protect the area by either light manual therapy, doing taping, or showing them positions that are safe and reducing of pain. From a nutrition standpoint, make sure you're eating enough food. Make sure you're eating a wide variety of foods, fruits, vegetables, meats, whatever is good for you. Supplement-wise, curcumin, fish oil, money in the bank. Maybe anti-inflammatories aren't a bad thing. I wouldn't take them in the initial 3 days, but maybe days 4, 5, 6, 7 if things haven't really shaken out. That way you ensure that you can slow down the tail end of the inflammatory process. Make sure you're getting sleep. Make sure you're just doing all the things that you need to do. And if you can move as much as you can within the confines of respecting pain and the healing process. So, great question, my man. Kelly M. Barman. Oh, okay. I'm going to answer this right quick before I move to the next one. Oh, man, everyone. Some DHA instead of fish oil from what I've been reading lately. Thanks, DK. So Kelly asked a quick question for me. As a new OT, I am debating between taking PRI or FRC-FR course. Any suggestions on which you would do first? I haven't taken any FRC personally and functional range release, so I can't really comment on how good they are or not. There's people who I respect who have taken it, and I've heard some love it, some are kind of mad about it, and some don't like it. So I don't really have a good answer in terms of the FRC. PRI, although I've changed a lot of what I do from what they do now, they still have some decent course offerings. Myokin, postural, and pelvis are a great starting point, and I would probably take them in that order. So I'd say if those are the two things, just because I can't speak on FRC and FR, I would go with PRI. Good question. Next question comes from Dave. Been waiting about this one. There's a few questions in this, and Dave is actually Bay. My Amica strength, I don't have thoughts on high doses of fish oil. Otherwise, I would answer. I just don't have any evidence to say whether that's good or bad. But I would say you could probably high dose it, or at least take 2 grams worth when you have an acute injury. Dave asks, should we finish upper body vertical pulling in a dead hang position? Is there benefit to reaching in the vertical pull, as there seems to be in the horizontal pull? Will the humeral head impinge on vulnerable structures of the joint? Should we be keeping the ball centered on the socket in a packed position during pull-ups. What would a functional anatomist say to this? Well, I'm not a functional anatomist, Dave, but I got something to say. So when you're finishing your pull-up, do you let it hang? Not like this. Don't throw your head forward, or do you pack down and then just do your pull-ups that way? Big Z be a fan of the former. Here's why. I think that there is no evidence that I'm aware of to support that letting yourself hang in a dead hang position leads to some type of subacromial impingement. In fact, there's a book, I can't remember the name, and Daddy O'Pops told me about this. I remember it when I was a student with Bill. He mentioned this book, and I will link it in the show notes as soon as I find it, because I just asked Bill about this book. And I'm laughing because as he was doing this, we were starting to do some bar hangs and things where you are letting yourself distract from that top range position. He filmed a video of me, and if you go to Bill's YouTube page, you'll see this exercise, and I'll link the exercise in the show notes. But there was a very funny comment on it that's probably not the most appropriate, but someone said that about me because it's a posterior view of me, so you can see the show. And I laughed about that. Neither here nor there. But if you look at this book, and like I said, I'll link in the show notes, but this doctor was talking about utilizing bar hangs for people with shoulder pain. And his theory behind it was that there's a mobilization occurring of the coracoacromial ligaments, among other things. And he showed some, I believe there were 3D CTs demonstrating that there was just bony approximation and stretching of these ligaments. And within those 3D CT scans, he showed that there was no subacromial impingement occurring. So just because bones contact to one another doesn't necessarily mean that impingement is present. What's likely occurring is you're just getting a mobilization of some particular structures. And I really don't think that that's a bad thing, especially in this overhead position. Also, if you think about the function of the rotator cuff, which is not just this, and this, which would be external, internal if you're listening on audio only. But what it does is it prevents the humerus from subluxing. So if I do that's tough. If I do something that's pulling me this way, the rotator cuff is going to suck it back into the socket. So you're probably getting a little bit of rotator cuff action with that as well. Not necessarily bad things. So also, a dead hang position is something that's very, very helpful for people with wide infrasternal angles. Because when I'm in this overhead position, what that's doing is that's pulling my rib cage a little bit wider a little bit farther out in the anterior to posterior direction. 1. 2, what it's also doing is because I'm putting the abs in a relatively eccentric oriented position, you get muscle spindle contraction activity. Allows for the external obliques to work a little bit more effectively. Allows you to close that infrasternal angle. That way you get a nice shaped rib cage, get that 90 degrees that we so desire, and that can improve shoulder motion. I've seen it. I saw it today, and I'll see it tomorrow. Maybe not, I don't know, I might suck tomorrow. But if I can do that to someone, improve shoulder motion, not have pain during, and we see that in some, well, it's not peer reviewed, but there is some evidence to suggest that, hey, maybe we're not getting impingement in this position. I don't see no harm in hanging. So hang, fam. Hang. Because I'll be hanging all day every day. My one caveat with this would be if that person has pain during the movement. Just don't do it. Like, find a different position. Like, that would be the one caveat in which I think you are running a risk of a potential impingement, like if there's pain. But is it even pain caused from impingement? I don't think we can make that jump. There's a few other questions within this, Dave, so let me answer them for you. Is there benefit to reaching in the vertical pull? I don't know if you have to do like an active reach. It's not something I coach, and it's not something I've played with. But I mean, when you're getting the hang position, you're still doing some favorable things to the rib cage, which is why we cue some type of reach with the thorax and say a horizontal pull. But even so, I don't even, like me personally, I don't cue that on the, like if I'm doing a one-arm dumbbell row and I'm letting it fall and I'm pulling it to my side, not past my side, but if I'm pulling it to my side, I don't do an active reach component, but I do make sure that I go all the way down so I get that relative hang position but in a horizontal plane. I don't think you have to, as you lower yourself, do something like this. But I also think, too, that as you ask later, Dave, this packing the shoulder position is not necessarily desirable. The reason why I don't think it's necessarily desirable is because if I'm packing the shoulder in a lot of individuals, that's going to create a relative increase in lumbar lordosis, potentially reduce the normal thoracic flexion that occurs, and then you're going to go to try to pull up in that position. You're going to likely bump into end range sooner. Problems ensue. Not something I doesn't necessarily coach, especially at that beginning phase of things. I think it's much more impactful to start from a hang position. That way you are going through the full excursion of not just the glenohumeral joint, but the scapula as well. So I don't see much benefit in packing the shoulder in this case. Because when you pack the shoulder in a good position, that also makes the assumption that the rib cage is in a good position underneath it. That's not always the case, especially if you're going in a down and back position. And we know that that has some impact on the axial skeleton and the ribs. So to me, what I would say is you go with the full hang, get your exhale position. Hopefully that allows the rib cage to scapula relationship to be on top of one another, and then you pull, fam, and you pull. Don't be afraid to hang. It's got a Zach Couples approval. Good question, Dave. Katie St. Clair asked me something. Megan Calloway's good up breast, Billy, hair check name. Oh, I will have to check out Megan Calloway. Never heard of her, Katie. Thanks for sharing. Last question. Comes from Chris, my friend. Chris, and actually Tyler a little bit too. Both dear friends of mine. Can you dive into occlusion and how it relates to posture / pain? The layman's version. Thanks. And then talk about TMJ. Man, I have been putting off this question. Thank you, Lucy. I've been putting off this question for a long time because I don't know if there is a layman's version to occlusion, but I'll do the best I can. Let me preface this. It's been a hot minute since I've looked into a lot of the dental stuff, even though that there was a... hang on, what's Bill saying? There is now an image of the hang position on your phone showing no impingement of the rotator cuff. My son. Pops, thank you. I would share it, but then I'll get sued. But if you guys buy the book, which I'm probably going to buy because this kind of rekindled this, I'll see what I can do. Or if you just DM me, slide into my DMs, I'll sneak you a copy. Last question regarding occlusion. I've been putting this off for a hot minute because I don't know if there is a way to keep it simple. I'll do the best I can. Let me preface, I'm not a dentist. I haven't been diving into this topic as much lately because I think that you can still get a lot of good stuff from here down before you go here. And also, before you go here, I would generally recommend making sure you have a bunch of other stuff in place before you do so. So if you aren't sleeping well or doing the best that you can to ensure a healthy sleeping environment, why do you think I'm wearing these? Doing that, if you're not eating a reasonable diet, whatever that means for you, I'm not going to talk about that yet. Stay tuned. And if you're not moving, if you're not exercising on a regular basis, I would not go here yet. And the reason why I wouldn't go here, it would be like if you went to go buy a Ferrari, but you don't know how to drive stick or you don't even have your driver's license, period. It's going to look pretty, but you're going to screw it up anyways because you're not putting good food into your mouth, you're not sleeping, you're not doing all these other wonderful things. So go ahead and please take care of that first before you go here. Moreover, sometimes if you go here, you're going to be paying the price of a Ferrari. Just saying. Occlusion. So what occlusion basically is, in the simplest way that I can mention or talk to it, is how well your teeth touch and in what position they touch relative to one another. If we're talking about measuring occlusion, there's three types, as do I, Dill. There's three types of occlusion. There's type 1, that's normal occlusion. And there's a type 2 and a type 3, which are malocclusions. These occlusions are named based on how well the first molar, so your big tooth, at the top and bottom, contact one another. So if you look in your mouth right now, go ahead. Just kidding, I can't show you. But what you're going to see is there's these little ridges on your teeth, or there's a little indentation in the middle of the teeth. This is how you measure occlusion. A type 1 occlusion should have the bottom portion of the teeth, if where I'm at right now is the front of the mouth, the bottom portion of the teeth should fit in that indentation a little bit in front of the top portion of the teeth. That's where they should contact. That's a type 1 occlusion. That's normal occlusion. That allows for you to have good contact, group function contact, which is canines. So those are your ones that you chew teeth with, and your molars to contact simultaneously. So that's your type 1. Type 2 would be if I were to move the bottom teeth back and they don't hit in that normal contact position. This would be an overbite. That would be a malocclusion. When that happens and the jaw is relatively retracted, that impacts the airway. That's problematic. That's really what all this occlusion stuff is about, is airway management. And a lot of the things when I would send people to a dentist for something like this is to make sure that you have adequate breathing through your nose. Because when the mandible is relatively retracted, that cuts or reduces the dimensions of the trachea. And so what do you have to do? You got to go into a forward head position so you can open up your airway. And then you're going to be mouth breathing. Ain't nobody like mouth breathing, fam. So that would be your type 2 malocclusion. Mal meaning they don't contact the way they ought to. The type 3 would be the bottom teeth are way in front of the top 3 teeth. So this would be an underbite. So your bottom jaw is way protruded. Or, think about it this way, your maxilla, so the top portion, is relatively retruded. That can also close off the airway. A lot of times these people will have very high palates as well, impinging on the nasal airway. You can't breathe through your nose. You try to breathe through your mouth. Problems ensue. Neither of those are desirable because they impact the airway. Now, a lot of times, you can have one type of occlusion on one side of your mouth and another, because a lot of us have normal rotational tendencies in our face, not just our body based on some of the asymmetries in here, but our face as well. And sometimes you can see people with really twisted faces. So that can also happen. What do you do about this? If you are a clinician or a coach, there's not a whole lot of things you can do about it because it's a structural problem. I have never been able to make someone a type 2 or 3 a type 1. What you have to do in this case is a dental referral to fix the occlusion. And that's regardless of if you do some good things for the neck, because neck is going to impact how you contact your teeth. Some of the your ability to truise or move your jaw in multiple planes is going to impact how you contact your teeth, and you would chase that first and foremost. But if the malocclusion is still present, it's got to be a dental referral. Now, what happens for these cases? It's not just braces, folks. Because a lot of times what's going to happen, and I've had friends where this happens, is where they have this malocclusion and they get braces. And either they're able to fit all their teeth in their mouth and they have to wear retainers forever, but say they quit wearing their retainers forever, or for a period of time, then the teeth go back to their normal position. No bueno. Or, even worse, you get some dentist, who pulls the teeth to try to fit them in the mouth. Also no bueno. Teeth are there for a reason. They help you chew, they help produce salivary amylase, but they also give you some sort of sensory awareness in terms of where your jaw is relative to your cranium and your neck, and they help with proprioceptive capabilities of hear up. They are somewhat of a sensory organ. I mean, it would be like if you removed a piece of bone, which is kind of what teeth is, anywhere in your body. To say that's not going to have an impact would be completely asinine. So what you have to do is fix the occlusion, and a lot of times that involves fixing the maxilla versus mandibular relationship. In the type 2 case, what you can do sometimes is get some type of dental splint, and I am by no means an expert at this. You can read some of my course notes with some of the cervical stuff that I've taken from PRI, or the mandibular stuff. It might give you a little bit of an overview, but again, too, like this is a dental referral. But sometimes you can just get a dental splint on the bottom side that helps pull the mandible down and forward. That can have somewhat of an impact on the occlusion in the short term, but there likely has to be something else done. What that is, I don't know. It really depends on what the maxilla looks like with these people who have type 2 malocclusions. If you have someone who's got a high palate, they might need some type of device, an ALF or a DNA appliance, to help expand the palate. And ladies and gentlemen, if you don't think you can expand the palate beyond a certain age, you're wrong. I have a colleague of mine right now who has a type 3 malocclusion. So he has the underbite and the retruded maxilla. And he has this device, and this is where we can dive right into the type 3, that pushes the mandible forward. And bone is being laid down. And if you look at his mouth right now, he has a huge gap between, I think it's his canine and either his premolar and molar. I forget where the gap is, but you can see this sizable gap. And the man is, in his 50s. I think he's 51 or 52 right now. I don't want to reveal who it is, but mid-face. Wait, actually, the man speaks. Sorry, Bill. Thank you. Okay, so Bill said type 3, or the class 3 malocclusion, requires a fixed growth guidance device. I'll link that in the show notes. But basically, he's been able to lay down more bone to bring the maxilla forward so the teeth can contact in that type 1 position. Really cool stuff. Now, in a lot of cases, after you've fixed the maxilla to mandibular relationship, then you get braces, which are the finishing touches, so you make sure you can get contact of all your teeth in the right positions. And so that would be, do you have the ability to contact molars on one side, canine to molars on one side, molars on one side without contacting anything else, molars on the other side without contacting anything else, canine to canine without contacting anything else, and then front of your teeth without contacting anything else. A lot of times braces are essential at fixing that. So to summarize this point, because I can't really go any further into it because it's out of my scope. And I mean, don't talk to me about what you need because I'm not a dentist. I would make sure you find a dentist you trust who maybe looks at some of these things. But to summarize, you got 3 occlusions. You got type 1, that would be where the bottom lower teeth are just slightly touching or in front of the top teeth. And they have this relationship where the bottom is a little bit more in front than the top. Your type 2 malocclusion would be your overbite. That's where the bottom teeth are behind the top teeth. So your overbite. Underbite. Type 3 malocclusion would be where the teeth are way in front, the bottom teeth are way in front of the top teeth. The midface is deficient, or the maxilla is retruded. To fix that, As a clinician or a coach, you do your best that you can to restore cervical and temporomandibular joint range of motion, and then send them to a dentist. Because something has to be done to restore the maxilla to mandibular relationship that you can't do, because this is a structural problem. Once that structural problem is fixed, oftentimes braces are indicated to make sure that you can contact your teeth in a normal manner, and that would be being able to touch molars on one side without anything else, canines on one side without anything else, and anterior guidance, touching the front teeth together without anything else. That's probably the simplest way that I can go over occlusion. If you can find the book and you want to be bored to tears and realize you know absolutely nothing, there's a book called Physiologic Occlusion. I don't even know if you can get copies of it anymore. But that one's a great one to go over a lot of this stuff regarding occlusion. I would say for 99.9% of you, don't read it. Why did I read it? Because it was the cool thing to do at the time. But really what the biggest thing that I got out of it, and maybe I would get more out of it if I worked with more people who I did refer to a dentist, but was the occlusions that I just talked about with you guys. So that's really all the questions that were had for me today, and I think that's a good stopping point. I want to thank all of you beautiful, sexy, outstanding people for tuning in today. I hope that the broadcast was a little bit less laggy. I've had a few people reach out to me saying that I'm all kind of wild and crazy, and so I decided to say goodbye to YouTube. But don't worry, this will be uploaded on YouTube if you missed portions of it. But now that you've been debriefed, I'm sure you're wondering, Zach, you are so awesome and dreamy, and I wish I was hanging with you this weekend. Where can I find out more about you? I'm glad you asked. First off, go to zachcouples.com. Here's what you want to do. You want to subscribe to the newsletter. It's in the top right-hand corner. Fill out your name, fill out your email, and guess what you're going to get? You're going to get access to almost 3 hours of me talking about pain and respiration. Not the same time, it's 2 different talks, but it's the same thing anyways. It doesn't matter. You're going to get that. You're going to get almost 50 pages of notes. You're going to get a free, acute to chronic workload calculator. If you are trying to help someone in a return to play scenario, I've found the acute to chronic workload to be damn near essential. You'll also get access to weekend learning goodies every Friday. I show you what Big Z be learning on the interwebs, among other things. You're going to get that. And of course, when my products come out, guess what? Guess who's getting the discounts? Them newsletter subscribers. Definitely check out zachcouples.com. Subscribe to the newsletter. Once you've done that, then what you're going to want to do is go to the online services page. Here's what you're going to get at the online services page. 3 things for now. 1, I offer movement consultations online from the comfort of your home. Say you're a little toy and you're not moving as well as you'd like to. Maybe you got some boo-boos and you've seen some people and it's like, I don't know. Maybe if I can move a little bit better, this would be helpful. Susan, I don't remember who the author is. I'm sorry. Bill might know if he's still tuning in. But if this will be linked in the show notes. Gosh, that's going to kill me. I don't remember. But yeah, if you're toy, you got some boo-boos, you want to move a little bit better, maybe you can't hit the squat depths that you're looking for, you can go to the movement consultation page. We'll work together. I'll spend an hour with you. We'll go through the movements you can and can't do, and I will give you activities to help fill in your gaps so you can be the effective mover or maybe the less symptomatic mover that you want to be. Hit me up for the movement consultation. Once you've done that, then you'll want to join the mentorship program. Say you are a clinician who maybe wants to talk about this because you're working with some people who have temporomandibular problems or other problems. Or maybe you want to talk about infrasternal angles because, hey, I want to incorporate this to my practice. Maybe you don't have anyone to bounce ideas off in terms of cases you're working with. Or maybe you're a trainer and you just want your people to deadlift a little bit better. I can help you out. Check me out for the mentorship section of my services. Last but not least, if you want straight up gains, if you want fat loss, if you want to improve your athletic performance, or you're post-rehab and you need some guy to train you, I can write you a good program. What we'll do is I will do a movement consultation with you. Carlson, thank you. I will do a movement consultation with you to start. We'll figure out what your movement capabilities are, and I will design a specific program for you based on your needs, based on your goals, and we will help you reach your goals. So check me out for the online fitness training. Once you've scoured ZachCouples.com and you're tired of seeing me on the cover photos and you just want to listen to my lovely voice, you'll want to go to the iTunes store and search for the Zach Couples Show. People, there's 39 other debriefs that you probably haven't listened to. You can listen to them on audio. Bring me into your car. Take me for a ride. And I'll take you for a ride down the knowledge route. Hit me up on iTunes. And please, if you already have, please write a review. Just I want the family to be bigger. So go ahead, write a review while you're there and listen to me in your car. Once you've done that, you'll probably want to hit me up on social media. Here's where you can find me. Of course, Facebook, facebook.com/ZCouples. Hit me up on Facebook. I'm also on that Instagram, baby. Instagram.com. Search Zach, Z-A-C, Couples, C-U-P-P-L-E-S. I'm also on Twitter. My handle is @ZCouples. And of course, if you go to YouTube and you search Zach Couples, you can find me. And you'll find some of the cool exercises I'm doing with my movement consultation people. Otherwise, thank you all for listening. I can't believe we've done 40 of these bad boys already. My, does time go fast. I want you guys to keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving. And I'll see you next time. Deuces.